Dr. Jenny Gowan is a practicing pharmacist, a teaching associate at Monash University, and a clinical associate at RMIT University. Jenny is an accredited consultant pharmacist and conducts her own company focusing on medication reviews in the home and aged care facilities, as well as quality use of medicine consultancy. She works regularly in community pharmacy, plus sessions in general practice at a community health centre. Jenny has published over 380 educational articles and presents hundreds of talks annually. In 2000, and she's a multi-award winning person, there's so many awards, but in 2016 she received the PSA Australian Pharmacist of the Year to deliver a keynote on risk management in practice. Please give Dr. Gowan a very warm welcome.
Right. Thank you very much indeed, Jean. But before I start, I'd say that you'd probably be one of the biggest risks to any practice. And we'd better watch out if you make an appointment and make sure your insurance is well paid. Otherwise, she will tell every audience what you did or didn't do and how much it hurt. Right. Okay, thank you, Jean. So my task in the next 30 minutes is to talk about risk management. Now, it's risk management with a capital L, and that means litigation. So that's what I'm trying to keep you safe. And I've got the pleasure of being involved in quite a number of medico-legal cases. So I'll share a few with you as we go through. So basically, if we look at the World Health Organization, no one should be harmed when they're seeking care, even if you're having a Pap test, Jen. So 1 in 10 people hospitalized worldwide experience safety failure or adverse event. 134 million adverse events every year. It's incredible, isn't it? It's a hazard going to hospital. So what we do is do no harm, and that was presented just recently at one of the WHO conferences with it. So hold on, we're going further forward. So if we look at some data that was commissioned by the Pharmaceutical Society by Libby Roughhead, who actually comes from the University of South Australia, we've got some change statistics that I think you will find rather disturbing. We used to say 230,000 hospital admissions. We're now saying 250,000 hospital admissions annually as a result of medication-related problems at an annual cost of $1.4 billion. That's 400,000 additional ED presentations. So you'll never be out of a job, you guys, particularly those that work in ED. 50% of this is preventable, and we're all part of it as well. So after hospital, it's even worse. 3 in 5 hospital discharge summaries, where pharmacists are not involved in their preparation, have got at least one medication error. I did say this was commissioned by the Pharmaceutical Society, so they are promoting pharmacists. You could also say that some nurses do an excellent job and some pharmacists don't do a good job. But on the other hand, we've still got a lot of people, 1 in 5 people, there's a high risk of readmission, and timely provision of the discharge summary doesn't often occur with it. 1 in 5 changes made to medication review were explained in the hospital discharge summary. So we sometimes don't know what is going on when, as a community pharmacist, you get a change, or if you're working in an aged care home, you suddenly get a change of medication. And a lot of people get confused. They come back from hospital and they start taking their existing medications, their previous medications, together with the ones that they've actually just been ordered on top of that. It doesn't stop. In residential aged care, and I've got a number of aged care homes, but 98% of those residents have at least one medication-related problem. And the group that were with me yesterday saw some of my old people, including my 110-year-old Marjorie, and all of those had a number of medication-related problems with it. And over a half are exposed to at least one potentially inappropriate medicine that you would not like to be on, knowing what you know now with that. Things such as oxybutynin, didropan, and you wonder why you're so confused, and yet you're classified as doubly incontinent. Why are they still on it? It doesn't stop when you get to the community. 1 in 5 people are suffering an adverse drug reaction by the time they receive a home medicine review. In my business, we've been doing this since it started, right at the very start, and we've done over 10,000 home medicine reviews. I'd encourage you to consider that as part of your practice. When I was working at the divisions of general practice, I used to run joint education events for the GPs, pharmacists and nurses. They were brilliant. The drug companies came along, they wanted to support us, we all spoke together, we all sat around the tables, and it was brilliant. To encourage the GP clinics and the GPs to take up the home medicine reviews, I used to have a slide that said, how many HMRs for your practice to get to Santorini for your holidays? The GPs would sit like this, and they go, ah. And at the end of it, they'd come up to me and say, Jenny, do you think you could just pop round to the practice and just tell me a little bit more about these HMRs? Money does speak, and it may keep you in a job, it may give you that extra day that you're wanting. I work in a GP practice myself now, and I have beautiful practice nurses who actually organise 3 HMRs for me every Friday morning, make the appointments for me. I go back to the clinic. Who do I deal to see first? The practice nurse who actually actions half the things that I've found. Then I go and see the GPs, then I write up the report. So it's very, very important with that. So 1.2 million Australians has experienced an adverse medication event in the last 6 months. That's huge. We've got more and more figures that are not reported as well. And interestingly, having just sat in on a session of the Kidney Foundation, over 1 in 4 older people prescribed medicines cleared by the kidneys are prescribed an excessive dose. And I think those figures were really concerning about how infrequently the renal function is checked. My biggest gripe is probably the person that is taking an ACE inhibitor or a sartan, plus a diuretic, plus a non-steroidal, particularly the ones that they can buy over the counter in the pharmacy or in the supermarket or in the 7-Eleven shop, the ibuprofens or the diclofenac or the naproxen. So watch out for those because they are really decreasing your renal function, and if they go and have their blood test and they're dehydrated, well, you're certainly going to show a very high serum creatinine with it as well. So teamwork, everyone has a part to play. It's not just us, it's not just you, it's not just the GPs. It's not just one person. It's not just the pharmaceutical companies, big pharma. It's not just TGA. It is combined, us all working together to get the best health of Australians for us. The prescribers, the nurses, the carers, the patients and their families. And sometimes the families are tricky. In some of my nursing homes, I've got some GPs who'll say, yes, I'll take on some more patients, but please interview the family first because I'm not having bad families. Not having difficult families. And you all know what happens when somebody goes to aged care and you've got family disconnect. The daughter's been doing everything, the son suddenly appears on the scene and wants to save mum and says she shouldn't be there, and yet the daughter's absolutely had it. So that's always a tricky one with the family. So what we're on about is safe prescribing, safe monitoring, and safe administration. And I could go further on about safe administration, about the person who can't swallow and the person who crashes up all their tablets or chews them and then ends up, as I was giving a case yesterday, of the isoptin 240 milligram, crushed once a day, goes like that, crushed, it goes like that, and you get a beautiful bradycardia and it stops. And good night, and we've had a death from that at the Austin Hospital. So it's all about teamwork, but it's about the barriers. What are the barriers to care? So polypharmacy, OTCs, we actually have now a new term called hyperpolypharmacy. And that's when they're adding on the OTC medicines together with the complementary medicines. And they often don't disclose those. They certainly don't disclose them to the doctors, more likely to disclose them to you if you're doing an over 75 home visit at the home. They'll disclose them to me after my hour interview, right at the very end. And they might say, by the way, this wouldn't be changing my INRs for my warfarin, would it? My daughters gave me these for Christmas, and you've got all, I thought I was getting some afternoon tea in one case, it was covered over with a nice tea towel, and all these tablets were there, all the complementary tablets, which were interfering with the coagulation with it. So we've got CAMs, complementary medicines with it. Excessive use of sedatives, psychotropic medicines. We've got the inquiry, the Royal Commission at present, which is driving us crazy because everyone wants figures. They want to know, are you less than 24% use of psychotropic medicines in your aged care homes? I personally do not care about figures. I care about the individual. And I have 4 Melbourne Health psychiatric units, and if they weren't on their mental health medication, we'd have a problem. What about the case I had the week before last, where a chap was admitted to one of my Melbourne Health homes. Reluctantly, the family insisted that he went there. He was complaining all the time, screaming. On the morning that I actually turned up later, the staff were in a great state of distress because this guy had got the nicest, smallest blonde nurse into his room, closed the door and trod on her toes and said, "I'm going to kill you," with his arm around the neck. And she screamed and screamed. Fortunately, somebody came and she went like that between his knees. Yep, and she was okay but traumatised. And she was on about 25 milligram of quetiapine only, where he should have been on a much higher dose. So he said that was the only way I could get out of this home. So we have a case for it. So looking at figures are not relevant unless we look at what's behind the figures and we look at the patient-centred care. Certainly non-drug things are the ones that I advocate most of all. So we have the excessive use of the sedatives, the psychotropics. We have inappropriate pain management. We have lack of awareness of potential education issues. We have people not taking their tablets in the community, more likely to take them in the aged care homes because they are actually forced to, but sometimes they will keep them in their pouches, you know, or they'll drop them on the floor and they'll go like that. They do that in their homes too, and then the dog comes along and eats them. And they put them in the fruit bowls before the pharmacy comes to take away the Webster because they don't like to see that they haven't taken their tablets. So I always look in fruit bowls. And if you're doing the over 75s, you'll find hordes of tablets there often because they're just popped in when the doorbell goes. Okay? So they have non-confusion, doubling up. And you won't believe it when you see that they're taking Lasix and furosemide and Urax as well. You think, this can't be for real. I give talks about this and she's actually doing it. And I had one the other day doubling up on a beta blocker. Then I had another one with a beta blocker. Instead of taking it half twice a day, couldn't cut it in half, so I took the whole lot at night. And then wondered why she wasn't feeling too good and a bit dizzy. So we've got belief systems that go with it. So we've got lots of barriers amongst us all with it. So we have met this lovely term called medicine reconciliation. And we really need this to be accurate for my health record because garbage in, garbage out. If you and I don't get their record right, then the next person that's looking at my health record is going to get incorrect data. And I can assure you that in the work that I've done, there is no correlation between the medication review that is on your systems that your patient is taking to what the pharmacy tells me that they're taking to what I actually find that they really are taking eventually after the hour interview. To start off with, you think you're going right, and then you look at their little Webster or their little $2 pack that they've packed, and you find that there's 2 tablets there, there's 3 there, there's 1 there, and those are supposed to be the night ones, and they're all wrong. And she's saying, I'm managing my medicines well. And then when you actually drill down, you say, well, do you think it would be handy if somebody else packed it for you? Well, yes, it would be, because I do find it really hard. But you've got to really delve down. It's a bit like doing a Sudoku puzzle. You've got to find all the clues, and then you get there. So it's very time-consuming. So certainly medication reconciliation is what we need to watch as well from the Safety and Quality Council. Lots of areas which we've already covered. The other thing that happens are similar drug names. Now, that can be very easy with incorrect selection when a doctor is prescribing and selects the Canesten vaginal cream to take 1 twice a day. And we see scripts like that as well, which is not really much fun when they meant to get Capitan, which was the row ahead of it. But also they can ring and they can say, will you stop the Lasix? The what? The Lasix. Do you mean Losec or do you mean Lasix? And particularly when we've got people where English is not their first language, we get lots of errors with those names. And you can see how easy it is with poor handwriting. We have handwriting still on the drug charts in the aged care homes that I get to, but don't think that we don't have errors with the computer generated prescriptions. We have them as well. So lots there for you to look at. So if we look at risk management processes, and I certainly do a bit of risk management for the community health centres that I go in prior to accreditation, and I sit on their safety and quality committees, which is why I sort of do have a bit of knowledge of what goes on, and maybe the recording of those S8s is not quite as good as what it should be. Yeah, you might want to check it. The balances also. What about the samples? What are the requirements for your labelling of your samples? You know, we've had a lot of people getting samples that are unlabelled or are incorrectly labelled or are labelled with a scribbled biro pen that's got smudged and the patients get it wrong. What about your records? And what about privacy? Privacy is really rife these days. And it was probably one of my biggest dispensing errors in my life was a privacy issue. On a Saturday morning I'm working and I call out a prescription for Mrs. Smith. Mrs. Smith, this is your last of your medication. It's an antidepressant medication. You need another script next time. How's it going? Yeah, I'm fine. Okay, that's fine. And a few minutes later, could I have the prescription for Mrs. Smith? Oh, God, I just gave it to you. No, you didn't. I'm Mrs. Brown. This one says she was an ex-teacher. You didn't relate to this, Jean. If you've given it out to one of the people from my school, I'm the local school teacher, I'm going to sue you for all you're worth. The legs go shake, absolutely shocking at this stage. So I was, look, fix it. And she also had the last of an antidepressant medication. The first lady didn't realise it was a different medication, so that was a problem as well, but it was the privacy issue. So fortunately, I got on to the lady and she came back and she didn't know this particular high school principal. But that just puts shivers down my legs now. That's a pharmacy error. You also have privacy errors. And when I'm in surgeries, I hear things that I shouldn't hear. I see things that I shouldn't see. I see things in the rubbish that I shouldn't see. It's just amazing. And we've got that fax machine that goes to the wrong fax person. So think about privacy. Audits. Lots of audits. Think about owing scripts. There is no legal entity as an owing script. And if you're asking a pharmacist to supply a Schedule 8 without a prescription, but your GP has written it up on the drug chart, that is not seen as a legal issue. And that pharmacist is liable for prosecution and losing their registration. It's something that has occurred over the years, and most of the practices are finding it very irritating to have this. And even when we get the nationally held medication record, we'll still have problems because you have to write the authority ones and you have to write the S8s. So you need to have a process so that you're not hounded by a distraught pharmacist who says, I can't supply those Norspan at 5 o'clock this afternoon, but the doctor's down playing golf, I can't get him, I can't get it up. Well, we have to get a locum in, and the locum comes in at midnight, and that poor patient doesn't get their patch on till midnight because somebody hasn't looked ahead to see that the script had run out. So it's processes that need to go with it. Occupational health and safety, we've got lots of that with handling tablets and opening antibiotic capsules. So you've got your protocols. Your recalls are absolutely vital, particularly this time of the year with your immunisation, but importantly so with things like denosumab injection every 6 months. You've only got 1 month either side to actually get that injection into the person. Otherwise, if you go beyond that month, your bone mineral density will revert back to where it was before they actually started having the prolia. So that is absolutely important, as is having the serum calcium done a couple of weeks before. So your recalls are important for your immunisation and for some of these other drugs as well, such as the B12. Prioritising where you're going, education, information for patients, and lots of opportunities for improvement. So I've got TGA alerts have changed. You've now got a black diamond, which is a bit like what we've got in the States. So some of the consumers are going to get very alarmed when they see black diamonds on their consumer medicines information, and that might actually discourage them from actually having the medication. So that's something that we need to do with counselling at all stages, from the doctors, from the nurse practitioners, from the practice nurses as well. Otherwise, they won't take their tablets. Okay, so we're going that way. Is your prescribing information up to date? Do you use guidelines? How useful are they? Are they for the person that you're actually got in front of you? And what was the date that they were written? So I'd like you as practice nurses to make sure that your information is correct and up to date for your GPs. Have you got therapeutic guidelines up to date? Have you got NPS? Have you got Australian Medicines Handbook? And all the various guidelines that I've listed there and your drug information sources. Let's look at John. Here's a script written out of your clinic. For colchicine, 2 to start, then 1 every 6 hours until relief. Dr. Oldie, who knows? Did this come from your clinic? Because if it did, you may very well find that John Smith ended up in hospital. If we look at this goes through it too. If we look at the MIMS, that is the correct dose. That was the product information when Colgout was first introduced. That has now changed because, well, colchicine is natural. It must be safe. It comes from a lovely crocus plant, a lovely yellow flower on it. But you know what we've been doing? We dose and dose until the person gets diarrhea, copious diarrhea. And I've had patients that have been hospitalised through that and just about died. So now we've got revised recommendations which appear in the AMH. And you can go and talk to the AMH round on the company stands there about it, because I said I was going to mention it today. You need to have the latest Australian Medicines Handbook, because they do change every year. This is a cost for your practice that is necessary. And you can see that you take 2 colchicine as soon as possible, then 1 hour later. You do not repeat until 3 days later. Is this happening in your clinic? Let's hope it is. If it's not, put this in front of them. What about the lady who comes in, the 84-year-old lady, and she walks out with a script for nitrofurantoin, 100 milligram to take every day, because she's been getting a lot of UTIs. Unfortunately, your prescriber has not caught up with the guidelines, and it is no longer recommended due to the adverse effects of the peripheral neuropathy from the nitrofurantoin, and we need to move on. So it's all about safe prescribing, gathering the information, clinical decision making, communication, decision, monitoring and review, and this is where you come in with your recalls. Checking recalls coming in, are they seeing you frequently? If they're on a care plan, have they come up or have they forgotten about it and escaped out of your clutches? So important for that continuity of care with it. We have lots of toxic conditions that are actually induced by medicines, and I've listed some of them there, the Stevens-Johnson syndrome, which we've experienced. So let's have a look at another case. Here's Mr. Oldie, and out of your clinic comes some Bactrim. You all know Bactrim, Septrim, been around for years. It is no longer advocated for people over age 65. He was allergic to penicillin. So would the pharmacist dispense it? Some would, some wouldn't. Where does the litigation sit? Okay, so cotrimoxazole, Bactrim, is no longer indicated in the older person because of increased number of skin reactions with it. Okay, so we could have a look at Liz, who I saw 2 weeks ago, and I was actually talking to the GP, and she had actually prescribed Bactrim. It was ceased after 5 days in one of my home because she had a severe reaction to it. But she had put it, and she argued, well, she had MRSA, and she was sensitive to clindamycin, and I thought that wouldn't be nice, so that's why I gave her Bactrim. But she developed rash and puffy eyes. You will note that she'd had erythromycin, ceftriaxone, doxycycline, and moxiclav as well. I looked further on her history, and she was, unfortunately, one of our absolute disasters. She is now at end stage. She had apixaban, and she'd been taken off that because she ended up having a fall, and she had a fractured noff. She was now put on digoxin. She was also on nitrofurantoin 1 a day. Whoops, whole lot of opioids as well. A bit of risperidone because she was getting a bit of upset. And on top of that, when I saw her, or didn't see her, because she was in the dental hospital, because she had osteonecrosis of the jaw, which was actually attributed, in this case, to denosumab, which is about 1 in 10,000. But was it really denosumab? And this is something that I'm looking into, because she'd been on bisphosphonates for a number of years prior. So of course the company would say it wasn't the denosumab, it was all the bisphosphonates before. But on top of that, she had incredibly bad gums, she was a smoker, she had gingivitis, so she was a high-risk person. So I hope she's out of hospital now. But you can see why we're on about litigation. Lots of other toxic conditions. We can look at some of the high-risk medicines. We go down to the pinch plus. So you all know this. So I've added down a few more onto the pinch. You've got your anticoagulants, you've got your dig, and so on. Let's have a look at some of them in the remaining 6 minutes that we've got. Anticoagulants make people bleed. Anticoagulants react with other medicines. We know that, and we've got to take extra care. So what about our next case of Betsy? Now, Betsy actually was a Royal Melbourne Hospital case, and you've got all the summary there for you, but the gist of it was that she'd had a lot of antibiotics, and she ended up with a thrush of the gums. So somebody said, use some, what? Dactyron, miconazole oral gel, which she did. INR shot up to about 10, and as a result of that drug interaction, she died about 4 days later. And you've got the full history that you can all read there. So, message, do not suggest miconazole with warfarin. Otherwise, you're likely to have huge litigation problems. And I will say, well, the person that suggested this, and it could have equally been a pharmacist, a nurse practitioner, or the person just going in and the shop girl from the pharmacy. And nobody checked, well, it should be Schedule 3, so they should have checked. Nobody said, are you taking other medicines? No, this was actually a nursing home case. Yeah, okay. So digoxin must be safe. Beautiful flower, lovely digitalis flower. Watch out, people make mistakes, people misread. I've had misreadings from 0.25 milligrams of the 62.5. You write it down and you scribble, and the pharmacist made an error in dispensing it. And in the pack were 2 0.25 milligram little white tablets. She should have had the little blue tablets. Fortunately, a personal care assistant picked that one up. Insulin. I've had numerous errors with insulin where you've got people writing 6U instead, and they have given 60 units. Oh, so please write units in full if you've got anything to do with insulin. Methotrexate. You all know about methotrexate? Once a week, isn't it? And for rheumatoid arthritis, for Crohn's, for psoriasis. What about the case that we had where the doctors ordered it 2.5 milligrams every day for a flare of his psoriasis? The pharmacist rang the doctor, and the doctor said, yes, that's what I want. And the pharmacist said, well, if that's what you want, I'll dispense it. And he did. And the patient died 6 days later. Now, where was the error? What happened? Who was legally responsible for that? I would not have dispensed it. I put it down to communication. I think this is where you come in, Jean, because I think that doctor was doing a smear test at the time. And there he was had his arms up there doing that, and he gets the phone call from one of your practitioners saying, it's an urgent one, do you really? Yes, of course I do, that's what I've ordered. And didn't hear and didn't think. The pharmacist, to me, should have stopped, paused, said to the patient, I'm not happy with this. I'm going to speak to the doctor a little bit later. He's possibly busy at present, and I'm going to really confirm that that is right, because that is not authorised, and never in my experience have I done that. So a very nasty one. What about NSAIDs? Well, what about NSAIDs? They're not good in older people, and I've really alluded to the point about the person whose renal function's not going well. So used appropriately, they're very useful drugs. They're anti-inflammatory and they give pain relief. But you've got GI problems, you've got renal problems, you've got cardiovascular problems, and you've got possibly sudden stroke with it. So used very carefully, short term, but they are the subject of a lot of litigation. And then what about paracetamol? A really good one to overdose with, except you don't know for a few days until the liver breaks down with it, and doubling up all the time. And then what about the nurse that actually gave the fentanyl to the wrong patient? So yeah, there's lots of things that we've got to watch out for, taking care with it. And what about potassium? You can actually kill people with potassium. We used to kill the guinea pigs when we were doing pharmacology years ago. We had an injection of potassium after we'd finished doing all the experiments of them. We don't do that now, but you can't get actually slow K and Dura K because they had traces of lead in them. So you can only get Span K, but Span K, or you can get chlorvescent. But chlorvescent does not equal slow K. It's twice as concentrated. So you need to think about that very carefully. And we've had a number of litigation events with people having spironolactone, an ACE inhibitor, and then having extra potassium. The heart doesn't like it. You get a lovely hyperkalemia. It's a very fast way to go. Thyroxine. Thyroxine is potent drug, absolutely vital, but some of our prescribers miss that lecture and they forget that when the TSH is low, that means that they are hyperthyroid, not hypothyroid. So, and then you wonder why the person is running around and needing some risperidone because you've been making them hypothyroid and their bone mineral density has gone right down. Litigation again. You've also got to work out health and safety concerns with it and the pregnancy risk, particularly people that are handling medicines, but also the person that doesn't tell you that they might be pregnant is one of your patients. Good luck in finding out. Sometimes they don't know. So please take care, and I just wonder if this one actually counts as an adverse drug reaction. Thank you very much.